Hello, Mr. Greenfield.
How are you? Can you hear me?
Yep.
Okay, thank you.
Alrighty.
Hello, Antonio. Hello, Jerry.
Hello, hello.
Hello. Hello. How are you?
I'm doing well. And how are you?
I'm good.
That's good.
I'm good. Yeah.
Alrighty. So with that, good afternoon, everyone. I want to welcome and thank you again for joining our second Difficult Decision Panel series. I'm Neetu, the Care Services Coordinator, and I'll be moderating today's discussion. Today, our Difficult Decision Panel series will focus on breathing and ALS. We'll learn about different perspectives from professionals, patients with ALS, and also caregivers that support our patients during these difficult times. And they'll also talk to us about the difficult conversations about breathing with ALS patients. We do have one more panelist who will be joining us today. They'll be joining us just within 5 minutes, so you'll see one more slide pop up. But now, without further ado, we will turn the camera over to Jerry. Jerry's our Care Services Coordinator, and she's also a respiratory therapist. Jerry's going to talk to us briefly about respiratory equipment and how it's used with ALS patients. So, and I'll be moderating our chat and the Q&A section. So I will, as soon as Jerry finishes her intro, we will start with the Q&A. Jerry, on to you.
Thank you so much, Neetu. I appreciate it. So I just sort of wanted to give a little bit of a background about respiratory breathing and ALS. I don't want to take too much time from the panel, so I'm just going to roll, y'all. And if you have any questions, please let Neetu know. So when we think about breathing, we automatically think about our lungs and we automatically think about oxygen. But I think what you need to really think about is you can divide breathing up into two parts. One is oxygenation, meaning getting the oxygen into the lungs, into the bloodstream. While that is very important, obviously, I want you to think about ventilation, because with ALS, ventilation is a huge issue. So what am I talking about? I'm actually talking about moving the air in and out of the lungs. The diaphragm is the muscle that contracts and relaxes to draw air in and out. And that's what's affected by ALS. So I tell people, if you've got good lungs before you got this diagnosis, most likely you've got good lungs with this diagnosis. So if you've never had COPD or anything like that, your lung tissue technically is not affected by this disease. It is your diaphragm. So what does that mean? Well, while oxygen is really easy to track, you put a pulse ox on your finger and you get your saturation level. The ventilation, we track more CO2 or carbon dioxide. Okay, I'm gonna call it CO2 because it's easier to say. And that's actually harder to track. How do we track it? Well, some DME, very, very, very few, have their DME, durable medical equipment respiratory therapist, has a little home monitor that you can breathe into, and it'll give you an estimated ballpark number of your CO2. Good way to track it. But I'm going to be honest with you, a lot of companies don't. It's a more expensive piece of equipment. A lot of DME respiratory therapists don't have that. So how do you really track it, really get the number? Well, you have to do it with an arterial blood gas. That's not that easy because it can't be done at home. It has to be done in a hospital or in a lab setting because it has to be processed right away. It's not like a tube of blood that you give when you get through your vein that they send off. it has to be processed or put on ice right away. So what happens if your diaphragm is affected and your ventilation is affected with ALS? It's going to build up your CO2, and this is a very concern. Once your CO2 builds up, it could lead to respiratory distress. If that's not dealt with, it can lead to respiratory failure. So how do you know? If you're not really able to track your CO2, how do you know what's going on? So some of the signs and some of the symptoms that you might see when the CO2 numbers go up are things like having a headache, being more lethargic or tired, more than normal. Sometimes folks, when their CO2 really gets built up high, get confused and can even, really confused, talk out of their heads. You may say, someone may say, I feel sort of dizzy. I just feel out of it a little bit. That's another sign or symptom. Or someone hyperventilating, or in other words, breathing more faster than you normally do. And sometimes skin can be flushed. So, okay, what do we do? Let's take it a step further. And how do we fix this? How do we do it? Well, I'm going to jump on my respiratory therapist bandwagon here, my soapbox, I guess you could say, and tell you oxygen is not necessarily the answer. And we tell people, do not, and I can't stress this enough, do not go on oxygen alone unless you are being ventilated. I'll talk about that in a quick second. Oxygen can by itself, while it may feel good, it may feel like you're getting a bigger breath, it can actually do more harm than good. It can actually cause an increase of CO2, which is what our problem is, and can actually send you into respiratory distress even faster. So the answer is, if you need oxygen, if you need it, always use it with ventilation. So what am I talking about with that? Ventilation is some form of mechanical help, okay? So we've got everything. You're going to see people on everything from a bipap, and I call them fancier bipaps, to ventilators. A CPAP, which you may have seen people on TV, or you may know someone who has a CPAP, is for sleep apnea. It is not for ALS at all. So some of our clinics will put people on a BiPAP at first. BiPAP is a fancy name for bi-level positive airway pressure, inspiratory and expiratory pressure. It's got two separate pressures, okay? Some people may put someone on a ventilator, and I want to talk about that word ventilator real quick. Ventilator's just the machine. It's not how it's delivered. So you can set the ventilator up, and basically with the BiPAP and the ventilator, what we say is, okay, machine, I want this person to get a big enough breath to, one, open up their lungs, and to two, blow off the CO2s. You can set pressures, you can do all this other stuff, but basically that's what the machine does. So I want to talk about non-invasive versus invasive. And when I use the word invasive, I don't want to use the word ventilator, but non-invasive can be done on a BiPAP. It can be done on a ventilator. It's just getting your assistance through some form of a face mask, okay? They're not using a trach or going internally, invasively inside. Now, invasive ventilation is some form of a trach, okay? But you can't use the BiPAP for the trach because it's not FDA approved. You have to use a ventilator. So the difference between NIV and IV is how non-invasive ventilation and invasive ventilation is how the support's delivered, whether it's delivered by some form of a face mask or whether it's delivered by a trach, okay? So what's the difference? Why do some people get BiPAP? Why do some people get ventilators? Some clinics like to go ahead and do a BiPAP. Most of the ones that I've been dealing with have gone straight to the ventilator. Some of the names of the ventilators are Trilogy, Astrals. They're all ventilators. It's just that's their brand names. I've had people, when you get just a BiPAP, your respiratory therapist may not be able to come out and monitor you as much. It's all an insurance thing, you guys. ventilators, insurance companies will pay for someone to come out on a regular basis and monitor you. And I say this because it's important that you understand this. On the day you get your BiPAP or your ventilator, they will have settings that are comfortable and work for you. But know that as this disease progresses, those settings may need to be adapted. So if you or the person you're caring for starts to show shortness of breath, they're working harder, you see them using more muscles, then you need to talk about having the settings adapted. So know that the settings may need to change over time. So what are some of the other machines that we see? You're going to see a suction machine. Now for a trach, it's going to be an internal deep, what we call a deep suctioning, same machine. It's just and they look old basically. Why fix something that works? There's two kinds of suction machines, a portable and a stationary. Stationary is more powerful. Most insurances will only cover one, and most people get the stationary. There's also a cough assist. That's a brand, basically a brand name. There's all different brands out there, but what it does is it makes a cough. When we take a cough, what do? We take in a big breath, build up pressure, cough out. That's what the cough assist does, blows in big air, sucks it right back out to bring up the cough. Your pressures on your machine have to be high enough to get that cough out. So if you have a setting that's low, you may feel like it's only the cough's only getting not high enough where you can get it out. The pressures need to be high enough for you to be able to get the secretions, the mucus, the phlegm up into the mouth where it can be suctioned out. And then there's what we call high frequency chest wall oscillation. I don't expect you to remember that. The brand name for that, and there are other brands out there, is the VEST. That's what most people see. Basically what it does is it's a lot of little pressures and frequencies that causes mucus to move from the lower airways up into the larger airways where they can be coughed out. Now, unfortunately, to me, that's a 1-2 punch. I think it's great. Let's move them up, let's cough it out. But we're going to be honest, insurance only pays for, in most cases, one. I've had a few people be able to get two. Veterans through the VA can get two, but most insurance companies fight it. If you're only able to get one, get a cough assist, because if you're not able to get it out, shaking it up, it's just going to go right back. So I think that's it. We're ready for questions, D2. I hope that gave a little bit of a background. So hope that helped.
And thank you so much, Jerry, for that detail. It was definitely very helpful. We do have one question. So the gentleman asks, my son has PMA, which is progressive muscular atrophy. So currently all the symptoms are lower motor neuron linked. He is adamant that he does not want any mechanical respiratory assistance. The gentleman is asking, should I be raising the question of preparing for the possibility that he may need mechanical help in the future, or just drop the subject altogether?
I think it's not a bad idea to talk about it. I don't have a lot of folks on my caseload with PMA. So I would talk to, I don't know if there's a clinic, I would talk to their doctor about where the path that doctor sees, but I do think it's important to talk about it. Okay. And thank you for that, because here's what I'm going to say. I think it's important for all of us to talk about it before it happens, because if you don't talk about it and let your family members know what you want, and something happens where you end up in the hospital, you may have a path that you don't want.
Yep. And we have another question, and I think that tracks perfectly into this. What are some of the things, and this is for the patients, that you took into consideration when deciding if you wanted to get a trach versus not get a trach?
So that's for them, right? Not me.
Yep.
hello, hello,
Mr. Briggs, we can hear you.
okay. I it took me going into the hospital twice before I decided to get my trach. My CO2 levels were very high, and so that is one of the reasons that I had to get that trach. Um, and also, um, the doctor said that when I was taking elderberry, that clothes need to have further respiratory issues. So they took me off of elderberry.
Okay. Thank you so much for sharing that. And another question for the families, it's how was this conversation started, whether it was at clinic or amongst families?
My decision to get a trachea was imminent because of multiple choking episodes, which caused visits to the emergency room. In short, when presented with the medical assistance device by medical professionals in the emergency room, I thought about my desires to be present for my children and to still have the opportunity to enjoy the things in life that I always have. The decision was easy.
Thank you, Randy, for sharing that. And that leads perfectly into our next question that someone asked. Were there any changes to your activities of daily living after you got trached or after you got a bipap?
Yeah, I can answer that. My daily living before I was straight, I was living at home with my parents and my sister. I was able to do more being in a wheelchair and getting around without a crate. But after getting a crate, you have to really decide on if your loved one can stay at home or have to go to a nursing facility that um, you would get a little bit better care 24 hours a day. Um, my family was more concerned on my health and me to get the proper care and get that around the clock respiratory care from a nursing home. So as a family, you would definitely need to talk amongst each other and find out your type of daily life you would have after having being treated, whether a nursing home is better for that individual or not. It depends on the family, how big your family is, and how well your family, your loved ones, will be able to take care of you.
Thank you,
And the
Mr.
first,
Green.
Yes, because of the need. Yes, because of the needle suctioning, thus an additional task for family. friends, and caregivers, there were changes to activities of daily living. The primary change was the additional work needed to manage the effects of the disease. Though there was a slight reduction in the activities that I engaged in, with the help from family, friends, and caregivers, I was still able to be an active participant in my children's extracurricular activities and life achievements. With great help, I traveled from Maryland to Kentucky on multiple occasions to support my son in college. Additionally, I have been able to continue to support my former players by attending junior college basketball games.
Thank you so much, Mr. Greenfield and Randy. We have another question, and this one is regarding the care needs. Did your care needs change after the procedure?
And yeah, is there, and money having done great, and yet the other have to have more equipment and so that my respiratory needs could be managed the right way. And also, whenever I would go out with family and to different events or other things, and it would require a more detailed assistance.
My apologies, I was on mute there. Thank you, Mr. Briggs. Another question we have is, what would my ALS procedure progression look like if I forego this procedure?
Can I answer that one?
Yep.
Or try to, I guess, or try to? I always tell people it's hard to talk about progression because everybody's so different. But if you decided, I'm so sorry. If you decided, it's either that or the dog barking. I told Nitu I was worried that my dog was going to bark during this. If you decide to not get on any kind of assistance, whether it be a bipap or a trach, your breathing is going to get more shallow and it is going to progress over time. So what we basically tell folks that have decided they don't want anything is to think about the potential for going maybe palliative care. And then if they don't want any kind of assistance at all after palliative care, going hospice. I can't give you a timeline, but basically what will happen is it's just harder to breathe and that CO2 will build up. You'll be able, real shallow breathing, just really, really hard that you're feeling that it's hard to get a big breath, which is where palliative care or hospice will come in and help alleviate the symptoms. Not fix it, but help alleviate the symptoms. And sorry about the phone ringing.
Thank you, Jerry. The next question we have for Ms. Jackson, it's specifically regarding a BiPAP. When you used a BiPAP, what type of mask did you find most comfortable?
So can you hear me?
Yes.
Okay. So I have the mask that covers my nose and my mouth. And as for the name of it, I don't know. but I do know it covers my nose and my mouth, and it straps around my head. I will say I use it every night, and I also use it during the day sometime. And I have found that it just rejuvenates me and it gives me energy. I have not been trached, but I do use the bipap and the cough assist every day. And I just feel like I'm a bit stronger. So I hope that's helpful.
Yep, that was.
I'm thrilled to hear you say that, because I always try to tell people, if you use it, it will help give you energy, and
Yes.
it really will. And I like the fact that you say you use it some during the day, because what I've always told people is, use it, let it help you. If you're struggling for breath, why use that valuable energy when you have something that can help you, that will make you feel better? As far as masks go, there's several different brands, there's several different kinds. There's the nasal pillows that just tuck up into the nostrils. There's a nasal mask, there's a full face mask, and there's a whole face mask. Most people will go with the full face mask, because if your mouth falls open with this mask, the air is going to blow out, path of least resistance, across the soft palate and out your mouth, as opposed to in the lungs.
Mm-hmm.
But I have seen people use the nasal pillows if they're able to keep their mouth shut.
And also, when I was in the hospital, they sent me home with 3 liters of oxygen. But I have to say that the bipap makes me feel better. I don't feel like the oxygen is needed or that it helps at all. And to your point, everybody is different. So, I mean, I have the oxygen here, and if I go out, I do take the traveling oxygen with me, especially in these hot days. But the bipap is really working.
We have another question. What do you do about skin breakage on the bridge of the nose?
I have not experienced that myself.
I can give you some suggestions for when I did home care a while. It's been a while, but the stuff's still out there. I've seen everybody use anything from, it's called moleskin. You can get it at the pharmacy. It's not a Band-Aid, but it is like a thing that you can just put right across there. They also have now mask liners that will, and you can, I've seen them at CVS, on the end cap at CVS, and you can, or online, and they just sort of help. And another thing is, after you finish wearing the mask, just wipe the facial oils off with a wet washcloth or something to try to keep it, and then clean it on a regular basis per however it says to clean the different masks. But they say wipe the oils off daily after using it.
Thank you, Jerry. Our next question is, what is something you wish you knew about the vent prior to making your decision?
Ventilator? What is something that you knew about the vent?
I wish I knew that using a vent would reduce the amount of suctioning. I would have started to use it sooner. I have only been using a vent for a little over a year.
Thank you, Randy. Jerry, quick question. I think Randy brought up a great topic where he said he wished he had used it earlier so that way it would help with the suctioning. Um, would you happen to have any recommendation or any expertise regarding suction machine when I know because certain patients when they have excessive saliva, how would you have that conversation?
I'm not sure if I quite understand the question, but I mean, if someone has excessive saliva, it's got to be dealt with. So, and especially if you're talking about putting on a mask and blowing air in. So our suction machines are one of the first lines of defense. There are, and I'm not sure if I'm on the right path on answering the question. So if I'm not, pull me back in. But there are basically different manufacturers, but two kind of suction machines, the stationary. And if you've got a trach, you're going to want the stationary one. Well, it's a double-edged sword. The stationary has more suction power. The portable one, obviously it's portable. And if your power goes off and you don't have any generator or anything, that one's good, but it's not as strong. It's not nearly as strong. I'm not sure if I'm answering on the right path on that question.
No, but I did get a clarification on it.
Oh, good.
Yes, it's also so with this excessive saliva, also with the respiratory, like the breathing concerns. Or if that makes sense.
Okay, I think I understand it now. Yeah, the saliva can be a big problem with respiratory devices, because if you're blowing in a higher pressure, if you're blowing in this pressure and you've got a lot of saliva, we've got a problem, because it could be aspirated, and our mouth is a germy place. So there are different things that you can do. There's medicines that you can take, everything from glycopyrrolates, scopolamine patches, the seasickness patches, atropine drops, a whole bunch of stuff, but it has to be dealt with. If you are a person that really has a lot, that it's a big issue, it has to be fixed before you go. And that's where your neurologist and your respiratory therapist at clinic will have a big say. Because it can be dangerous if you don't have that fixed or worked on. I've also had people have Botox injections in their salivary glands for that. Fine line between putting in too much and totally drying you out, putting in too little and it not working. But I have had very few people do it, but I have had some people have success in that. But it has to be repeated every 3 months or so. I hope that was a better answer.
No, thank you, Jerry. And our last question for today, for our panelists and the families that were joining us, how did you plan for the changes in your breathing needs?
Do you mean prior to having the issue?
Yep.
Well, if I can be 100% honest, I did not prepare. I ended up in the hospital because of shortness of breath. And that's when we realized that there was a problem. Because prior to that, I had not had any issues with breathing. It just happened. So I didn't have time to really prepare and talk to my family about what I wanted and what I needed. But that is where a very strong support system is needed so that they can work on your behalf.
Yeah, I do agree with Simone. When I've been living with ALS for about maybe 16 years, and my progression is very slow. It's a lower motor neuron that normally travels up my spine very slowly. So now I'm at a point where my diaphragm got weak. When I first got the trait, I was not prepared at all. I went into respiratory failure at home, and I did not know. I had the flu, and I did not know that my body was building up a lot of fluid in my lungs, and I couldn't cough that great for about a week. When I went into respiratory failure, um, I had uh, a decision to make. My lungs filled up, pneumonia set in, and I
Mhm.
had several operations to clear my lungs. Most hospitals don't carry cough assist machines, and I did not know about the cough assist until after I got trained. So my decision on having a trait would have been I would have made a different decision knowing if a cough assist would have worked with me without the trait, meaning using the mask, as Jerry was saying. If I was able to use the mask to cough out a lot of information and secretions, then I may
Mhm.
not have been trait so soon. But by being trait for about 4 years now, it's really taught me a lot about having a trait. Um, I was on the ventilator for 10 months. I weaned off the ventilator and was on the trait collar, which is what I think Anthony is on right now, where it's just oxygen going through. Um, your speech is going to change. Being on trait collar, where you're speaking one word at a time, and you're really using your diaphragm to push through your vocal cords each breath. The reason why I'm talking good now is I've kind of adapted to the ventilator. There are different types of traits that you can get. One is with a balloon, or what they call cuffed, and there's one without the balloon, which is uncuffed trait. I was on a cuff trait for about 10 months on the ventilator, but as I was waiting to get off the ventilator, I went to my EMT doctor, and they put a uh, non-cuff trait in me, and I was able to breathe and talk really well, meaning I heard my voice for the first time in 10 months after being trait. When you're trait and the balloon is open, you're basically, the ventilator is doing all the work for you. My diaphragm was strong enough to breathe independently, but too weak to cough to get all the secretions out. Right now, my cuff is half open, half closed, so the ventilator is still breathing for me, but I'm getting enough air to come out through my vocal cords, and I'm able to talk a little better by being on a ventilator. But if I'm not on a ventilator, I'll be saying one word at a time for each breath. And I did that for about 2 years. And I really think by doing that, that helped strengthen my diaphragm. Eventually, I am going to go back to weaning and getting back on trait collar where I won't use a ventilator as much, maybe at night to sleep, but I would like to go back on trait collar where I can breathe independently. The secretions comparing the two, ventilator versus just having oxygen blowing through your trait, I found it be kind of even. I was still probably getting suction every 6 to 8 hours and using the cough assist maybe every 12 hours. Um, yeah, so I'm in the process now of returning home. I've been in a nursing home for about 4 years, but I'm having a lot of family support and friends have really helped me decide to go out into the community on my own, especially during the COVID times. Nursing homes, I'm not having a good feeling about nursing homes during this time because a lot of nurses and CNAs are quitting, and you're not going to get the best care as you would get being at home. But that's a whole nother topic. Okay, someone said it.
That's good, Will. Yeah.
Nitu, can I just add like a couple final things? I've been jotting down notes as people have been speaking. And I do think it's real, whether you want to trach, whether you don't want to trach, you don't want to wait till the problem arises. Because I said earlier, what happens is you might end up with respiratory distress. They're going to put you in the hospital. The first thing they're going to do when they put you in the hospital is put a face mask on you. So because that's our only card we've got to play, basically, you guys, we've got to ventilate you. So if you're already doing it at home, hopefully it won't get to that point. But it's real important that you make the discussion and you let people know what your feelings are, because it has happened that people have gone into the hospital and have not discussed it with family members and have been approached saying, you got to do this, and ended up being trached where they didn't want to. So it's definitely a decision that has to be talked to in advance. I also, and as I said just a few seconds ago, the answer to the increased, I think it was Antonio who said he ended up in the hospital because of that real high CO2 levels. And that's the answer to that, once again, is ventilation. And I think it's real important to know whether you go on a bipap or a ventilator non-invasively, or whether you go invasively with a trach. It's important to understand that the disease is, you have, especially if you're trached. If you're trached, you've answered the respiratory answer. You've given that an answer. You know, the machine's going to be able to breathe for you. You fix that part, but the other parts of the disease will still progress. And it's important that you know that, because I've had some folks who thought, well, if I do this, everything will stop. And unfortunately, that's not true. And I wanted to say one other thing. There is a thing, and I loved your talk about the cuffed and non-cuffed trach. Fantastic. There's also a thing that you can put on a trach called a speaking valve, but this respiratory therapist that you're talking to right now is not a big fan of a speaking valve with ALS. And there are people out there who are like, she doesn't know what she's talking about. But I'll be honest with you, I think it takes a lot of energy to force air up through that speaking valve, and energy is so important. It's so important, and we want to be careful how we use it. And then once again, be careful. If someone's telling you you need to go on oxygen, make sure you're talking with your respiratory therapist at clinic, or a respiratory therapist and a neurologist who understand the disease process.
That is so important. If I can say, just to add to that, that last statement you made is so important, because I find that many hospitals, they are not, they don't know much about ALS. And that makes it very difficult in decision making. So that's another topic for another time, but I just needed to say that.
You're right. You're right. There's a lot of misunderstanding.
Yes.
Yeah, the best support for ALS is the ALS Association and the clinic, the ALS clinic. The clinic will give you a lot of information as far as pulmonary. And I wish that I would have gone to the clinic 6 months before having respiratory failure, because I would have known that my diaphragm was getting weak. They have devices that that you can blow into to kind of monitor and test the strength. And then your neurologist would recommend, hey, Will, you may want to consider being trach, because if you get pneumonia or whatnot, and inflammation fills up in your lungs, you're gonna have a hard time coughing it out, and you should start preparing for it sooner than later. And then if you get into a nursing home, you may have to decide on your Medicaid needs and whether your assets need to go. That's a whole nother topic about that. But your assets need to come out of your name to someone else's name. But that's more long-term planning. But as far as the clinic and the ALS Association, they are wonderful, wonderful, wonderful information and advice you can get to better prepare for being trach. Yeah. Or any symptoms that you have, whether you need a wheelchair or medical bed, they are wonderful to help you with preventing butt sores, going to sitting clinics if you're in a power chair. I mean, it's just all sorts of information you can get from both organizations, whether it's the clinic or the ALS Association. So I think those two bodies that those two groups I rely on a lot for a lot of information I've got. But hospitals, nursing homes, they have no clue. Some of the nurses don't even know how to take care of a trach. I mean, as far as cleaning, suctioning, some of them have never experienced suctioning. Like I said, hospitals, most of them don't even have cough assist. They have the chest rest, and they have another device called a Medinib, which is a newer device that vibrates and does oscillation. And I've used that a lot, but I find out when you just vibrate your lungs and get nebulizers and treatments, you are loosening up the secretions in your lungs when it comes to coughing it out. I could be in the hospital for 3 weeks or 4 weeks, can't cough, and they do not have cough assist for you. So I just got one, ALS, Dr. Byatt and GW gave me one for about a month ago. But I wish I had it the 4 years that I've been going in and out of hospitals. That is a much needed device, especially with trach. That is a mandatory device.
Thank you so much, Mr. Greenfield, for that.
Okay.
It's interesting that you say that, because when I worked in the hospital, you're right, we did not have cough assist. And it wasn't until I got in the home care field that I even saw cough assist. But I wanted to tell you all, there's an app, and it's on both Android and the App Store for Apple, and it's called ALS Key Medical Information. And I'm going to see if you can see. Well, I don't know about that, you guys, but it's an app, and it opens up, and it's got where you can put in contact information. It's got a little communication board, but it's got information that says, you know, I have ALS, my speech might be slurred. That don't give me, it literally says, if I'm short of breath and or have low SpO2 or your SAT level, do not give me oxygen unless I have another respiratory condition that requires it. I may need non-invasive ventilation. So it's a nice app. It's free online.
Jerry, can you tell us the name of the app again?
Jerry, you're mute.
One day I'll figure this whole computer thing out, you guys. It's not going to be today, obviously. It's called ALS Key Medical Information. And I just went to the App Store and just Googled ALS Key, and it brought it up. And it brought the one that I brought up, it brings up the, well, when I open it, it's going to open, but it looks like I don't know if you can see it, that
Okay,
right
yeah.
there. It says ALS real big.
Thank you.
Nice
Thank you.
thing to have.
We also have it on our website. So I've shared the link in the chat. It talks about all the resources that Jerry just mentioned. So that's one way to access it. But those are all the questions we received for today. Before we end, I do want to thank all of you, Jerry, Mr. Briggs, Gregory, Ms. Jackson, and Mr. Greenfield. Thank you so much for taking the time today to come here and talk about your experience and just share your thoughts. Is there a last word that you guys want to share with our families?
Well, thank you for this opportunity and to share. And I would like to say to all of the ALS person that this Zoom keep fighting, keep fighting. I am so proud of each and every one of you, and I will continue to pray for you as well.
And I continue praying for you, Antonia.
Very good.
And there's a few of our attendees that are also saying thank you to you guys for sharing your guys' experience today.
You're welcome. You're welcome.
Thank
with-
you also for the opportunity to be on today, both as a panelist, but also it gave me the opportunity to learn more about ALS and being trached. It was very, very helpful. And if I could say to everyone, we will make it.
Yours. Yours.
Yes.
We
Amen.
will.
Yeah.
Once again, thank you so much, everyone. Before we do sign off, I do want to remind you next week, Wednesday, again, from 1 o'clock to 2 o'clock on the 21st, we'll be having another difficult decision panel series. That one's going to be about hospice and palliative care. Just like this one, you will receive a reminder. But in the meantime, if you guys have any questions or comments, you're more than welcome to reach out to me and I'll be happy to help you guys. And you guys enjoy the rest of your
Good luck, everyone. God be with you always.
Amen.
Amen.
Very good.
And
Right. Thank you.
Bye.
bye-bye.
And,
Press leave.